All right, thank you very much. Hopefully everybody's feeling refreshed and ready for the next session. We're going to talk about contemporary management of, well, really high-risk lesions diagnosed on breast core needle biopsy. And I have to say, this is one of my favorite presentations. It's evolved over the years I've given it because of the way practice has changed. But so hopefully you enjoy it as much as I do. All right, let's see. Uh-oh. Okay. All right, so as by way of outline, we'll talk briefly about correlation and radiologic-pathologic concordance, discuss how core needle biopsy diagnosis guides next management steps in radiology, surgery, and oncology. And really, I actually touched on some of that in the earlier presentation, so this will be more about lesions that we didn't cover so much in my first presentation. Similarly here. And then other considerations, we'll talk about consequences of core needle biopsy and other high-risk scenarios. So let's begin with a definition of high-risk lesions. This is a breast lesion that carries an increased risk for the future development of breast cancer. At least that's how oncologists think of high-risk lesions. But it's also a breast lesion that carries suspicion of a more sinister pathology, i.e. DCIS or invasive carcinoma, around or in association with a non-malignant breast lesion. And that's how radiologists think of high-risk lesions. So excision of lesions in the second category has historically been recommended when those entities are diagnosed on core needle biopsy. But as we've talked about, this has been evolving in more recent years. So high-risk lesions conferring an increase in subsequent breast cancer risk, as you well know, include things like atypical ductal hyperplasia, lobular carcinoma in situ, and atypical lobular hyperplasia. Proliferative disease without atypia, UDH, sclerosing adenosis, those entities really don't confer a significant, or at least they confer only a minor increase in subsequent breast cancer risk. So these are not in our high-risk lesion category in terms of subsequent breast cancer risk. And then high-risk lesions from a radiologist's perspective are those associated with frequent upgrade on excision. And this is historically ADH, lobular neoplasia, intraductal papilloma, radial scar and complex sclerosing lesion, flat epithelial atypia, and mucocele-like lesions. So as I said, the reason these were historically associated or managed by excision, and this was because excision upgrade rates ranged from 0 to up to 30% in the literature. And so that meant really that they had to be excised. But there are a number of factors that have influenced a change in management so that contemporary management is somewhat different. We have higher resolution imaging that has led to detection of smaller and smaller lesions. We have use of larger gauge needles and vacuum assistant devices, which provides greater sampling and or results in complete removal of the lesion. And we also are better now at radiologic-pathologic correlation. So we, I think, make more of a concerted effort in that regard. And, you know, through radiology-pathology correlation conferences, for example, and direct conversations with our radiologists. And then finally, this sort of trend toward de-escalation of therapy in the cancer field. So it makes sense to try and de-escalate for these benign lesions, right? If we have newer, better data that can inform a more conservative approach. So just a few words on clinical correlation and concordance. So determining radiologic-pathologic correlation is key. We need to know going into review of the biopsy whether we're dealing with a mass, calcifications, or a non-mass enhancing lesion. It's also important to be mindful of lesions that are easily overlooked pathologically. And then also to be aware of common diagnostic dilemmas and their management impact. And again, I talked more about that this morning. So as you well know, the pathologic diagnosis on core needle biopsy must be concordant with the imaging impression. And knowing the clinical history, the imaging findings, and the differential diagnostic considerations that the radiologist has in mind is key to a thorough evaluation. And any discordant diagnoses must be reconciled, and that's either through repeat biopsy or it may require surgical excision. And as I said, this can be facilitated by Radiology-Pathology Correlation conferences. We hold these once a week in smaller sites. Maybe you might want to do them every other week or once a month, but they can be very useful. So core needle biopsies for calcifications, the core needle specimens should be x-rayed to confirm capture of the calcifications. And ideally, the cores with the calcifications should be submitted in a separate jar from those without the calcification. It's also important and helpful to have access to the specimen radiograph because the calcifications that you see on the slide should correlate with what's seen on the radiograph. As you well know, we can often find these teeny tiny calcifications in lobules, but they may not be the correlate for what's seen on imaging. And if you know that they're in a nice rounded cluster or distributed, scattered throughout the specimen, that can be helpful as well. And then finally, it's important to document the location of calcifications in the report, as this will guide next steps, may guide next steps. Core needle biopsies for mass, non-mass enhancing or architectural distortions. Here, it's important to identify the pathologic correlate. I'll talk about the importance of not overemphasizing pseudoangiomatous stromal hyperplasia. I find that I order levels more frequently in this scenario than I do in calcifications, quite frankly, but obviously in both cases, levels will be important if you don't have the radiologic correlate. And then you need to document if you don't find a mass after doing additional levels. So what about calcifications? If you don't find the calcifications, think about calcium oxalate crystals. They're commonly associated with apocrine cysts, as you well know, and you can crank down the condenser to highlight them if you don't see them just in the usual plane of focus. Get additional levels. If it's just 1 or 2 blocks, I get the levels. If I find that they've given me 6 or 7 blocks, sometimes I x-ray the blocks first to see which ones really have the key calcifications and then get levels on those. It sort of just depends on your histology lab and workflow. And then you can look for holes or tears in the tissue. So here's an example of that scenario where, do you see how there's this line through the tissue here? Oops, that is probably where the calcification was. Sorry, the circle is a bit off par here, but the calcification was here and it gets drawn through this tissue as the histotech is cutting the section. So that can be a clue to a missing calcification. We really are still in the sort of learning phase with MRI-directed biopsies. We have some data now that helps us know the distribution of MRI non-mass enhancing lesions. About 60 to 70% of biopsied lesions are benign, with most of those benign changes being fibrocystic disease. Actually, PASH is quite commonly one of the findings, can even be normal breast tissue that they see as a non-mass enhancing lesion. 10 to 15% of cases are atypias, and the remaining 20% represent malignancies, which are obviously the ones that they're going after and need to rule out. The challenge for the radiologists is that the benign and malignant lesions detected through this modality share similar morphologic and kinetic characteristics, which means that it's hard for them to separate out on the imaging features alone. Hence, we get so many biopsies, of which about 70% are benign. So vague masses or developing densities, sometimes that can just be variably fibrotic tissue with no discrete mass forming lesion. Sometimes you'll see that it looks just like normal tissue, but it's standing out in a background of fat, and you can sort of imagine how that might be an imaging target. Same goes from PASH on core biopsy. You can see some pseudoangiomatous stromal hyperplasia here. Could that be the imaging correlate? Certainly could. Again, I try to be careful about overemphasizing that because it's quite common. It's found in about 25% of all benign breast biopsies. But I think through experience, you can sort of get a feel for whether you believe it to be the imaging target. And again, those are the types of cases that we may discuss in our RAD-Path correlation conferences to see if it really might be a match. So just a brief word on correlates that are easily overlooked. Apocrine cysts, these are very common, and so you might not give much kind of intellectual credence to the identification of apocrine cysts. But when they're clustered like this, they might be the explanation for an ultrasound detected or even a mammographically detected mass-forming lesion. So just think about whether that could be the correlate. Cysts can sometimes be difficult to recognize because the epithelium can be sloughed off or may not be captured on the edge of the core biopsy. But look for this sort of little area of fibrosis that runs along the length of a core biopsy, or very attenuated epithelium. So if you're just focused on the middle of the core, you might think that you don't have any findings. Look along the edges as well, because that might be the imaging correlate. UDH, we don't tend to think of as a mass-forming lesion or an image-detected lesion, but you can see here this tiny little, probably 2 or 3 millimeter nodule. You can well imagine how it stands out from the background adipose tissue. And so again, thinking about what the radiologic correlation could be. And as I said, the level of detection of lesions by our radiology colleagues now is such that they're finding minute lesions and sometimes biopsying them. Here's another entity that can be commonly overlooked. I've seen it in a handful of cases where it's been described as unremarkable or benign breast parenchyma. And what cues my eye into this particular diagnosis is this change in the stroma here. You see how there's this, I think of it more as kind of a waxy look to the stroma here. And then once I see that change, I then start thinking about this entity, searching around for lymphocytes. This is an example of lymphocytic mastopathy where you have sort of keloidal-like change. You should have epithelioid myofibroblasts. Those can be more difficult to identify. And as I say, you'll find these tight clusters of lymphocytes around the ducts, lobules, and vessels. I don't often outright call it based on these features, but I'll describe the features and say that it may raise the differential diagnostic consideration of lymphocytic mastopathy. But the point being, it's not a completely normal breast biopsy. And in a patient with a mass-forming lesion, it could be the explanation. Here's another example of something that was called normal, and it was a mass-forming lesion. And actually, I think the target is this area of possible scarring, some sort of bland spindle cell proliferation. I don't really have a diagnosis for this, except that I know that it was the imaging target. The patient went on to have an excision, and it was the same sort of finding. I think she had had some prior surgery, and so it likely just represents an area of scar. But again, putting it all together, what is the imaging finding? What is it you're looking for? And do you have it in the biopsy? So as I say, be aware of clinical and imaging findings, as well as the radiologist differential diagnosis and your own pathologic differential diagnosis for the different scenarios. I do obtain levels quite often in core needle biopsy, in the setting of core needle biopsies, mostly for mass-forming lesions or putative mass-forming lesions. As I said, less often for calcifications, usually because I tend to see them, but obviously if I don't, then I'll get them. As both Eddie and I stressed, I think judicious use of immunostains is wise. You can get yourself into more troubles if you're not doing a directed, informed kind of panel of immunostains. And then in the setting of core needle biopsies, I think it's important to be conservative. Don't overcommit when the findings are equivocal. And then I'll talk about at the end the importance of establishing concordance for all cancers at the time of receptor sign out, especially triple negative cancers, and to check the patient history. So we'll get to that at the end. So we really talked about this earlier, but I just have one additional example of atypical ductal hyperplasia, just because this really is sort of the main entity in this high-risk lesion category, because it's the one remaining sort of benign diagnosis where there's really a high risk of upgrade on excision. It's still around 20% DCIS or invasive cancer found at the time of excision in patients with a diagnosis of atypical ductal hyperplasia. But this particular example that I'm about to illustrate here is one of these threshold lesions, which actually falls the other way, where, as I was talking about this morning, I think it's important not to over-categorize borderline lesions, and I mean borderline on the ADH low-grade DCIS threshold, as being DCIS, because that can result in too much surgery, too much unnecessary surgery. So this lesion here, which spans about 2 millimeters, it is an atypical population. We have a monomorphic epithelial cells. I would argue that it's incompletely filling the space, at least the architectural atypia is not completely filling the space. So I would have called this ADH. It was called low-grade DCIS at the outside institution, and the patient had a mastectomy. I can't even remember, she may have had bilateral mastectomies, but certainly ipsilateral mastectomy, and there was nothing found on excision. And so this just really emphasizes the need to be conservative in the setting of a core needle biopsy specimen. And we talked about this before, but just to sort of stress that the WHO advises a conservative approach. I just mentioned that upgrade rates remain high for ADH on core needle biopsy, and excision remains the standard of care, except in some tertiary institutions where they have sort of ADH tumor boards, where they might decide, looking at the radiology, whether all the calcifications have been excised, what the features are on histology, whether those patients may be eligible for observation. Not really going to talk about this because Eddie's going to be talking about it tomorrow. But here, Radiologic-Pathologic Concordant Incidental Classic LCIS no longer requires excision, and she'll elaborate on the data there. But just to include it in your handouts, here's an example. And really now the upgrade rates have come down substantially, such that we don't need to excise these anymore. There remains some variability in the management recommendations given for high-risk breast lesions detected on image-guided core needle biopsy at US academic institutions. This data is a few years old now, as you'll see, but this is just how, lobular neoplasia is being managed. It's still sort of, at least 4 or 5 years ago, was still being managed by excision, but hopefully a newer update will soon indicate that more and more patients are being managed with observation alone. So radial scars and complex sclerosing lesions, and I'll spend some time talking about this entity in the next session, the small glandular proliferations session. But these, I think, can be quite tricky. And here, just to sort of start up front with what the management is. So incidental radiologic pathologic concordant radial scars no longer really require excision, although I'd say that's still a sort of decision in evolution. But certainly excision remains the standard of care for most image detected radial scars and complex sclerosing lesions. And the challenge here is really that these entities can mimic carcinoma clinically, radiologically, and pathologically. But there are some imaging features that support a diagnosis of radial scar, or at least favor a diagnosis of radial scar. If there's a more lucent center to that stellate mass, or if the arms of the stellate mass have sort of a greater reach, those are softer signs that you might be dealing with a radial scar versus an invasive carcinoma. But in an individual case, it's probably quite challenging for the radiologists to be sure. So I'm fairly confident that most cases go on to biopsy. Pathologically, We look for a lobular-centric pattern. So that's that low power impression of lobular centricity, central elastotic stroma, and those features will favor a benign process. But in a core needle biopsy, that can be quite challenging to recognize because you may not get a piece of it that, you know, helps you identify that. So immunostains to highlight the myoepithelial cell layer can be useful. So this actually may be one of the this may be one of the slides I showed in the earlier session, where you have this sort of elastosis, you have some entrapped glands, you have epithelial elements radiating out. And so when you see that kind of radiating process with the central elastosis, you know, you should think about radial scar, and then, you know, obviously evaluate the epithelial proliferation based on the criteria that we've both been speaking about to help you recognize it as a benign process. Here's another example of a very nice radial scar. Not so much elastosis in this one, but you can see that sort of central nidus with the entrapped glands and the epithelial elements radiating outwards. Starting to get a little bit more complex now, maybe a little bit more alarming looking, greater irregularity to the contours of these epithelial nests. But still, it has kind of this central nidus and radiating epithelial elements that should make you start from a point of radial scar or complex sclerosing lesion. This one, I think, more like complex sclerosing lesion because it's less well-formed. You know, there's not so much a single central nidus. It's sort of more irregular. So in that kind of setting, I tend to use the language complex sclerosing lesion. From a radiologic perspective, radial scars are 1 centimeter or smaller, and complex sclerosing lesions are larger than 1 centimeter. I don't think we have those criteria quite so strictly defined in the pathology literature. So here's just higher power of that prior slide showing you the myoepithelial cell layer and the heterogeneous epithelial cells of this area of usual ductal hyperplasia within a complex sclerosing lesion. Contrast that with a tubular carcinoma, which is a mimic for radial scar sometimes, and you can actually even have elastotic stroma in radial scars, in tubular carcinomas. So it can be a little tricky. So you can sort of see some elastosis. These are very often older patients. But there's more of a haphazard distribution to how these glands are distributed within this field here. It doesn't look like small glands within the center, confined to the center. They are percolating out and about. And then, you know, I think that there's some cytologic atypia in the in situ process here. Adenosis is not really sort of exactly in the radial scar complex sclerosing lesion category, but sclerosing adenosis is also challenging on core needle biopsy, especially if it's involved by atypia, as in this example here of LCIS and adenosis. And I have to say, I really struggled with this case. I kept going back and forth. You know, I thought it was in adenosis, but then I couldn't be sure about whether I was seeing any myoepithelial cells. It wasn't perfectly lobular centric. It seemed to sort of have a little bit more of an erratic arrangement of the glands or nests. And so I did employ myoepithelial cell immunostains in this case and was able to confirm that this was LCIS in adenosis. But just another example of how this can be tricky in core needle biopsy setting. And this is a second paper where we looked at the expression of myoepithelial cell markers, this time in benign sclerosing lesions of the breast. And like with DCIS, we also demonstrated that in the setting of complex sclerosing lesions and radial scars, you sometimes saw reduced expression of myoepithelial cell immunostains. And so to be careful, again, in this setting, to use multiple immunostains and to use the morphologic features and just to sort of be aware of this potential pitfall. So for radial scars, complex sclerosing lesion, upgrade rates to DCIS or invasive carcinoma, while lower in the past, remain high enough that around 5%, 5 to 6%, that excision is generally indicated for image-detected lesions and certainly is indicated if there's any involvement by carcinoma. But I would say that those incidental ones or small that are completely enclosed in the core biopsy, those patients aren't always undergoing excision. And then mucocele-like lesions, we I don't think have a spot where we're particularly talking about these. Here, again, there's been evolution with the management of these lesions, whereby radiologic-pathologic concordant mucocele-like lesions without atypia no longer require excision. Of course, anything with atypia will require excision. And as with the sort of radial scars, lobular neoplasia, and as I was mentioning with FEA earlier, older data is confounded by cases that were discordant, where maybe there was an irregular spiculated mass in a patient with LCIS. And so that kind of finding, it's no wonder there's discordance and upgrade rates in those cases that, you know, there's a radiologic lesion of concern. So there's bias in the older literature and there's bias in the cases undergoing excision. And that's why historically we saw higher upgrade rates. Here's just a nice example of a mucocele-like lesion associated with microcalcifications. This is why this particular lesion was detected. And the challenge for us here morphologically is that the differential diagnosis includes some significant things. Mucinous carcinoma, maybe metastasis, pretty unlikely, but possibly. And then mucin pool status post neoadjuvant systemic therapy. Mostly we're not getting core needle biopsies in a patient who has received neoadjuvant therapy. We're usually getting excision specimens, and you will have seen that sort of mucinous change, I'm quite sure, in the excision specimens. But there are some patients on clinical trials where they're doing an interval core needle biopsy in patients who have received some neoadjuvant therapy. So just something to bear in mind on occasional cases. So here's a perfect example of a potential pitfall where you have a core biopsy with stromal pools of mucin, no epithelial elements here. So could this just be stromal mucin, or do we need to worry about mucinous carcinoma? Well, if you have something like this and none of the cores show any epithelial elements, I would advise getting some levels. Indeed, this case did have epithelial elements in a separate core. It didn't require levels, but you can see how you might get a sample in a hypocellular mucinous carcinoma, which just has the pools of mucin and no epithelial elements. And so, you know, that's the potential pitfall. Oh, how did I do that? That's the potential pitfall there. So we can do some hypothetical illustrations of this where you have your core needle biopsy going through a stromal pool of mucin. Is this a hypocellular mucinous carcinoma, or is it actually a mucocele-like lesion? It's a mucocele-like lesion. And then here where we have stromal mucin, turns out to be another example of a hypocellular mucinous carcinoma. Now, people have talked about using the presence of neovascularization in the stromal mucin, and that can be helpful. You can highlight that with some immunostains. But I think I would get levels to see if I can find any epithelial elements if I only have stromal mucin. Looking at the literature now, if you pool it all together, I think it was Kim Allison looked at 441 cases without atypia reported over a 20-year period, and only 15 upgrades to DCIS or invasive carcinoma. So an upgrade rate of 3.4%, which is the threshold, that's below the threshold for our radiologists. So if you just have mucocele-like lesion without atypia, then those patients don't require excision. Among patients with atypia, the upgrade rate is almost 20%. So you can see that the presence of atypia is very important in management of these lesions. So again, just to summarize, we don't need to excise those without atypia, excision for those with. So here's just a summary table for these radiologically high-risk lesions and what their current upgrade rates are, and why we always excise ADH in the US at least why we excise image-detected radial scars and complex sclerosing lesions, and there's a little bit of flexibility in the other entities. So again, just to summarize, in the presence of RAD-path concordance, these lesions no longer require excisions in routine cases. So moving now to discuss some of the consequences of core needle biopsy. I talk about this a lot, and I often think, well, we're all aware of this now, but I was telling Eddie that I just came across a case where this was missed. So I think it's important to review and reiterate some of the complications of core needle biopsy. So of course, you're always going to have granulation tissue scarring and biopsy site changes in your excision specimen following core needle biopsy. We saw an example of infarction in that may not have been following core needle biopsy, but it was infarction in a papillary lesion. That's where you commonly see that. That can happen following core needle biopsy. Sometimes you can get squamous epithelial line cysts. Sometimes the cancer can be completely excised by the core needle biopsy. They're doing more cores, they're using larger gauge needles and vacuum assistance and finding smaller and smaller cancers. So you might have that kind of consequence, which requires its own workup just to make sure it wasn't a misdiagnosis on the primary core needle biopsy. But what I want to focus on is epithelial displacement. So epithelial displacement is the finding of benign epithelium or DCIS in the stroma or vascular spaces. Or it's the finding of invasive carcinoma displaced into vascular spaces, giving you artifactual LVI, although how you can tell the difference is very challenging. You can also get displacement of epithelial elements, benign or malignant, to axillary nodes. So in an excision that has been diagnosed as invasive cancer, you can have displacement of epithelium to the nodes and then have the sort of complexity of having to decide if it's truly metastasis or not. So how common is this? Well, it's inversely related to the core needle biopsy interval. It's frequently associated with papillary lesions. It can occur following liposuction or some sort of cosmetic procedure. And I would say just anecdotally, it's fairly frequent. It's reported in about 40% of cases, but I think you can find it quite often in your excision specimens. Challenges with encapsulated papillary carcinomas. I think, nearly every single excision specimen, at least in the US, is preceded by a core needle biopsy. And as I mentioned, papillary lesions are especially prone to displacement of epithelium because, as Eddie was saying earlier, these are very friable lesions. So it's not surprising that the needle going through this large papillary mass will bring some epithelium with it back into the stroma. And then you can have the challenge of having to decide whether you're dealing with microinvasion or a T1A lesion. So here are some examples. Here's a core needle biopsy of DCIS. We can see the chemotonecrosis and calcifications. Here's the excision specimen on that case, and you can see the DCIS up here. And you can see the core needle biopsy tract with the granulation tissue and hemorrhage. And your eye obviously is drawn to this area here where we have smaller, more irregular nests, really look quite atypical. They're directly in this sort of very cellular looking stroma, which one could, if unaware, interpret as a desmoplastic or tumor stroma, but this is actually the granulation tissue. It's the biopsy site, it's reactive. And so anytime you see this kind of morphology, you really have to attribute it to displaced epithelium and not a focus of invasive carcinoma. Here's another example of a complex sclerosing type lesion. You can see the myoepithelial cell layer. And then here is the core needle, the excision specimen from that case where you can see lots of displaced epithelium in this same biopsy site stroma. So not to misinterpret it as a focus of invasive carcinoma. And often the epithelial elements that are displaced, they can have almost a squamoid look to them or degenerated look to them. They can look quite alarming, quite atypical sometimes. Even when the lesion that was biopsied was benign, they can look quite scary. Here's another case. And what happens is it tends to have this sort of sprayed look to it, where the epithelial elements are sort of shot out into the stroma. Here, just to show you, you can look for macrophages, you can look for hemosiderin to cue you into the fact that this is displaced epithelium. Here's a benign intraductal papilloma that was diagnosed as such on core needle biopsy. And here's the excision specimen. And this case, if I recall correctly, had been diagnosed as invasive carcinoma on excision. And it was the surgeon that thought this was unusual and asked for a second opinion. And we were able to say this was actually displaced epithelium following the core needle biopsy. This was several years ago now, this case. But you can see this sort of squamoid appearance that you have. Often there are single cells that are distributed here that, you know, again, if you start doing immunostains in this scenario, you can really alarm yourself, because keratins will highlight all these single cells and really make you worry about invasive carcinoma. And similarly, P63 or any myoepithelial cell marker may be negative, because the epithelial elements are the ones that are dispersed, and the myoepithelial cells don't often go along with the lesion. So this is the case I received, actually my colleague received this week. Here is the core biopsy that had actually been diagnosed as atypical ductal hyperplasia, which is why the patient underwent excision. But you can see that there's this sort of dense sclerotic stroma. I actually think this looks more like usual ductal hyperplasia. There are slit-like spaces. It was really only this tiny area of epithelial proliferation, at least on the slide that we received for review. The primary institution did do ER and CK5/6, but didn't trust it or misinterpreted it and still called it, as I say, atypical ductal hyperplasia. So the patient went on to have an excision, and here's the excision. And you can see perhaps some of this sort of papillary benign intraductal papilloma from that area of sclerosis that was in the core biopsy. And you can see all these scattered epithelial elements. Here they are on high power. And I agree, they look pretty alarming. That, you know, you start to look at these on high power, maybe there's a mitotic figure there, looks very unnerving. CK A1, A3, and P63, if you're thinking invasive carcinoma, is going to make you think invasive carcinoma. So really immunostains are not helpful in this case. And it's really the fact that it's all this biopsy site change plus a benign lesion, I think that should lead to a very circumspect call in this case. And so what can you do? You should look for invasive carcinoma away from the biopsy site. Look for a recognizable pattern of invasive carcinoma. Those patterns that I've just been showing you are really what I would say is a recognizable pattern of displaced epithelium. That's exactly what displaced epithelium looks like. And so you want to find some sort of conventional component of invasive carcinoma away from the biopsy site. For LVI, you want to be extremely conservative if there's only DCIS or a benign lesion. And again, if there's invasive carcinoma, look for involvement away from the biopsy site. The presence of LVI, you know, can happen just because of this needling procedure. So, you know, you want to be careful about that. And then for the lymph nodes, fortunately, if you have a lymph node, presumably the patient has a diagnosis of invasive carcinoma, otherwise you wouldn't have the node. But usually if it's displaced epithelium that's the differential diagnosis, it's isolated epithelial cells. And so it wouldn't change management. So I tend to sort of be descriptive in that scenario and say, you know, I've got isolated epithelial cells. If it's associated with hemosiderin, that could be helpful in favoring it being displaced epithelium. If they look well preserved and look exactly like the invasive carcinoma, then you could favor isolated tumor cells. But as I say, management-wise, it doesn't affect the management situation. So moving now to other high-risk situations. So I think the other high-risk situation that we encounter now is the fact that more and more patients are receiving neoadjuvant systemic therapy. And so we don't really have that opportunity for a second look when we receive the excision specimen to really say, oh my gosh, I made a mistake, you know, it's a benign lesion or it's not invasive carcinoma, because now the patient is going to receive, you know, chemotherapy, something significant that, you know, has considerable morbidity, potential morbidity. So it's very important to review the H&E slide at the time of receptor sign out, especially for triple negative cancers. So at our institution, we sign out the H&E, that's finalized, and then the ER, PR, and HER2 are reported as an addendum, as a second report. And so it may not be me who signed out the original case who's looking at the ER, PR, or HER2. So we have to, you know, you have to make sure you're fully invested in the case, in the patient, in your colleagues in the department, to make sure that you're checking thoroughly, confirm that morphology is consistent with breast carcinoma, ensure there's no prior history of another cancer. You should be doing that at the time of the H&E review, and consider further workup if findings are atypical or in the setting of a history of cancer. So here's a typical example of a triple negative breast cancer, right? So we've got sheets of high-grade tumor cells. Sometimes you have areas of necrosis or fibrosis. And so, you know, it's not especially distinctive. It looks high-grade, it's solid, there's no tubule formation. Here is a mastectomy specimen from a patient who received neoadjuvant chemotherapy for a diagnosis of triple negative breast cancer. Looks pretty similar to what I just showed you on the core needle biopsy. Here it is on high power, sheets of highly atypical epithelioid cells, I'll say. There's necrosis, no gland formation, nothing especially distinctive about this, I would say. But it transpired that there was no response to the chemotherapy, which is a little unusual in triple negative breast cancers. They have a better response than our other breast cancers. So there was one area in the excision, the mastectomy specimen, that had slightly different morphology, maybe slightly spindled cells, maybe a slightly eccentric nucleus. Well, it transpired that the patient did have a prior history of another cancer. And here is the melanase stain in the patient. So this is an example of metastatic melanoma in a patient who was diagnosed as having triple negative breast cancer. And honestly, I think it's so easy. That is an easy mistake to make, because if it doesn't have melanin, or those really round red nucleoli, or you have a really upfront history, it's not easy to you have to keep an open mind. And in any triple negative cancer, I think you have to think about this. So don't forget that not all cancers in the breast are breast cancer. Consider this when the morphology is atypical. But I would say, the morphology doesn't always cue you in. It can be a very subtle sort of shift in what they look like that should make you think about it. If there's no DCIS, that's another clue. But again, I would say these high-grade triple negative breast cancers, they often don't have DCIS. Core needle biopsy may not capture the DCIS in a large lesion. So that's not always, reliable. You can't work up every single case without DCIS. If there's a history of another cancer, and then, as I said, triple negative cancers. Malignancies metastatic to the breast are rare, fortunately. They represent only about 0.2 to 2% of cases. Common primary tumors are melanoma, serous carcinomas, lung carcinomas, and lymphomas. So actually, this is a different one. This was actually a patient that had colon cancer that was metastatic to the breast. So luckily we had that history, because I think that would be fairly impossible there. Switching gears slightly, this is another breast core needle biopsy. And here we have tumor cells infiltrating in sort of irregular nests. I think this could look like a grade 2 invasive ductal carcinoma. Maybe one thing that's a little bit funny is that there are some normal TDLUs in between, but that's pretty soft. This case somebody did look up, or we did have the history. So the patient had a history of lung cancer, so it was worked up to see, and it turned out to be metastatic lung carcinoma. Your saving grace, if it wasn't, if you didn't have the history, is the ER stain. So look here, the ER in the metastatic lung cancer. Now, lung will show some ER positivity in many situations, but it will be this weak heterogeneous pattern, which you wouldn't expect in a grade 2 invasive ductal carcinoma that looked morphologically what I just showed you on the H&E. So if you hadn't recognized it, that would be the job of the person looking at the ER, PR, and HER2 to question the possibility that that was a misdiagnosis. So about 10% of lung cancers can show focal ER expression. Some lung cancers can actually show DCDFP positivity, and these might be the ones that are TTF1 negative. And then conversely, some breast cancers can show TTF1 positivity, about 2%. And that can be variable, it can be weak, but it can also be quite strong. In this paper by Robins and colleagues, they showed some nice images of that. So it's just important to use caution when interpreting small biopsies, either from the breast or from the lung, right? To think about whether it's lung or breast cancer in the lung, or breast or lung cancer in the breast. So just again, to be mindful of these different things. Now we have a number of different markers at our disposal that can help with identification of lesions as primary breast cancers. Obviously, our breast biomarkers, GATA3, GCDFP15, and mammoglobin, and now TRPS1 as well. And the combination, of course, will improve the sensitivity and specificity. But remember, as I've already mentioned, that some of these stains will be positive in other entities. You know, we were very excited about GATA3 in the beginning, but we see some staining of that in other entities. So just be careful about interpretation there. And then, of course, absence does not exclude breast origin. So think about that too. You know, just because something isn't staining with GCDFP and mammoglobin doesn't mean it's not breast cancer. Like Eddie, I don't really have any experience with TRPS1, but this is a newer marker that's reported to have high sensitivity and specificity for breast cancer, especially in triple negative breast cancers, where high expression was seen in almost 60% of triple negative breast cancers, which is better than for GATA3. Again, we're seeing some staining in other carcinomas, but combinations are reported to be more helpful. SOX10 is another one that's reported to be useful in triple negative breast cancers as well, because about 40% of breast cancers, including metaplastic carcinomas, can stain with SOX10, so that can be useful in your differential diagnosis with other tumors. And then here's a fun case for us pathologists, not for the patient, obviously. This was actually an intraparenchymal lymph node. So it was a node, and the radiologists thought it was an intraparenchymal lymph node, but they thought that there was some irregularity and some calcifications on imaging studies. So they did a biopsy. And what we had was this epithelial inclusion or proliferation within the node, and this sort of somomatous looking calcification. Actually, the epithelium looked pretty bland. And so the question was whether this was some sort of, well, was it breast cancer within an intraparenchymal lymph node? Was it some sort of inclusion or rest, or was it serous carcinoma? And actually what we did in this particular patient was, it was WT1, this slide stained with WT1. We informed the oncologist or the caregiver, and the patient was worked up. So this was primary presentation of serous carcinoma of the peritoneum. Here's another example. It's a case of papillary carcinoma in the breast. You can see that it looks like papillary carcinoma. It looks like there's a bit of a capsule around it. You know, what is the clue here that this might not be primary in the breast? Not much. I would say maybe the only sort of thing to make you think differently is that the nuclei look kind of high grade. Usually our papillary carcinomas, as we've heard, are low or intermediate nuclear grade. So higher grade lesions is a little bit unusual. It was worked up, 7 positive, 20 negative, ER positive, negative for GCDFP and mammoglobin. Still could be breast, right? But it did turn out the patient had a prior history of serous carcinoma. And this looks pretty similar to what we have. And so comparison can be your best ancillary tool. And you see here that they look fairly similar. And here's the WT1 staining in the breast lesion. So metastatic serous carcinoma of ovarian origin. So this actually is the most commonly misdiagnosed or missed metastasis. These are often ER/PR positive, so a pitfall that you wouldn't pick up necessarily on your biomarker studies. PAX8 and WT1 are most useful, with 87% being positive for PAX8 and 96% if you exclude mucinous, which of course wouldn't really be in the differential diagnosis so much with breast carcinoma. Just be aware that mucinous breast carcinomas can be WT1 positive, although that's weak and focal. So as I've sort of scattered throughout my presentations today, heterogeneous expression of ER is not typical for invasive ductal carcinoma grade 1 or 2. So you should always review the slides to exclude misdiagnosis either of usual ductal hyperplasia involving a sclerosing lesion or less likely a metastasis such as lung or some other entity. So here's actually a different pitfall. This case was called invasive ductal carcinoma grade 2. I'm showing you here on higher power. You can see how it looks kind of monomorphic. The stroma looks a little bit funny. So you can see how it would be called invasive ductal carcinoma. The nests are a little bit irregular. So I had the ER stain to review, which I'll show you momentarily, and it showed a heterogeneous pattern of expression. And I said, well, this looks a little weird. So, you know, we had the, you know, we took another look at the H&E, and this is actually in truth a deeper level. So it was a little more apparent, but you can see that there's sort of a circumscription to the lesion. And so it's not really infiltrative. You know, I was showing you an area of higher power here, which looked infiltrative, but when you look on low power, it looks like a more circumscribed lesion. And when you see something like this, one of the things you should think about is an adenomyoepithelioma, as we heard about earlier. She's an older patient. It was a lobulated mass. And here again is the higher power. And, you know, honestly, the myoepithelial cells can have lots of different appearances. They can be, you know, sometimes they look like they've got a lot of cytoplasm and they're easy to identify. Sometimes they're more spindly and very subtle and difficult to identify. The stroma can be a bit of a clue, but here's the ER. So this was a clue to the fact that it was misdiagnosed in this case. And so that's discordant. And so you should go back and review, and it was corrected to adenomyoepithelium. And here's just an excision of an adenomyoepithelioma showing you the same kind of pattern of circumscription, lobulation, same morphology. And here's P63 just highlighting all the myoepithelial cells. So always be mindful of unusual looking tumors, triple negative cancers. I'm not saying that we need to work up every single case to rule out metastasis. You just need to pause, consider the possibility, and anytime it feels a little funny, then that's the time to look into the history a little bit more and consider working up a little bit more. We always have to ensure receptor status is concordant with the H&E findings. So any ER low positive tumors really should be high grade. They shouldn't look like that adenomyoepithelioma. That's not concordant with ER low positive. We have to be accurate with our percent positivity. Otherwise, we might exclude patients from triple negative therapies or trials. That low positive category now often are eligible for clinical trials or triple negative therapies. So, you know, try and be accurate on that 10 to 15% threshold. Ensure low-grade tumors are strongly and diffusely positive. So anything that morphologically looks like a low-grade tumor should have 99% expression of ER. And then also HER2. So be careful about HER2 versus HER3, HER2 3+, because FISH is not mandated for all IHC3 positive tumors. And also, of course, now we have to be careful about our 0 to 1+ cancers. So be careful about that. Patients with palpable HER2 overexpressing tumors are often candidates for chemotherapy, whereas ER positive HER2 negative patients may not. So again, you have to be very careful about what you're calling 2+ versus 3+, and ensure the morphology is compatible with HER2 positivity. So those also should be high-grade tumors, apocrine histology, abundant eosinophilic cytoplasm. Those, you know, there's sort of a phenotype for high-grade, for HER2 positive tumors. So always re-review and consider further workup if the findings are unusual, receptor status is discordant in the setting of a history of another cancer. So in closing, hopefully you feel that we've reviewed core needle biopsy diagnosis and how that influences next management steps in radiology, surgery, and oncology today, as well as discussing the importance of radiologic-pathologic correlation. I've talked about management of high-risk lesions diagnosed on breast core needle biopsy, and we've discussed the importance of considering non-breast primaries and the need for careful correlation and accurate reporting of breast biomarker studies, particularly in the era of neoadjuvant chemotherapy. So with that, I'll stop and we can take any questions.